in general. Specifically, we're tackling the absolute maze of medication, hormones, and the risk analysis that surrounds it all.
Mm-hmm.
It's a topic where, quite honestly, the headlines have done a lot more terrifying than clarifying over the last 20 years.
Oh, absolutely. It is arguably the single most confusing area of women's health. And unfortunately, fear has really done a good job of drowning out the physiology.
Right.
You just mentioned hormone therapy at a dinner party, and everyone has a very strong opinion, usually based on, a new snippet they heard 20 years ago.
Exactly.
Yeah.
So our mission today is to strip that away. We are unpacking Chapter 31 of the source material, which covers menopausal, perimenopausal, and postmenopausal hormone therapy. It is. And we are not just skimming the surface of hot flashes or bad. We're going to get into the granular details of the physiology, the HPO axis, the specific findings of the Women's Health Initiative, both the bad and, importantly, the good,
Yes.
and the pharmacology that dictates why a patch is so different from a pill.
And that distinction is vital. I mean, if you don't understand the mechanism, how the drug actually moves through the body, you can't really evaluate the risk properly.
So let's start by setting the terms, because menopause gets thrown around as a catch-all for, middle-aged and tired or just getting older. But medically, it is a very rigid finish line, isn't it?
It really is, and it's a retrospective diagnosis, which is just incredibly frustrating for patients. You essentially can't know you have reached menopause until you look backward.
How so?
By definition, menopause is the permanent cessation of menses following the loss of ovarian follicular activity. But clinically, we can't actually make that call. We can't diagnose it until there have been 12 consecutive months of amenorrhea.
12 months. 1 full year with absolutely no period. So if a woman goes 11 months without a cycle, and then on month 12, she has a period.
The clock resets. You are back at month 0.
Oh, that's brutal.
It is. You are not in menopause. You are still in what we call the perimenopause.
That feels like a cruel game of chutes and ladders.
It can really feel that way. Perimenopause is that whole transition zone. It begins with menstrual irregularity cycles getting shorter, maybe longer, heavier, lighter, just all over the place. And it ends strictly 12 months after that final period. That is the turbulent time where the hormones are really swinging wildly.
Okay, let's unpack the physiology of that shift. Because to understand why we treat it, we have to understand what's breaking, or I guess what's changing under the hood. We need to talk about the HPO axis.
Yes, the hypothalamic pituitary ovarian axis. This is the control center. Think of it like a very, very sensitive thermostat system for your reproductive health.
A thermostat, okay.
So up in the brain, you have the pituitary gland. Its job is to stimulate the ovaries. It does this by producing 2 key hormones: follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH.
So the pituitary is the boss, and it's shouting down at the ovaries.
Get to work. Make eggs. Make hormones. Exactly.
Get to work.
And when the ovaries are young and functioning normally, they respond. They produce estradiol from the dominant follicle and progesterone from the corpus luteum after ovulation. Now, here is the crucial mechanism that keeps everything stable. Those steroids, estradiol and progesterone, send a signal back up to the pituitary.
A feedback signal.
It's called negative feedback, yes.
So they send a signal back up saying, message received, boss. We have enough hormone down here. You can stop shouting now.
Precisely. It turns down the thermostat. It keeps the system in a beautiful, delicate balance. But in menopause, we face the loss of ovarian follicular activity.
The factory shuts down.
That's a great way to think of it. The factory shuts down. The ovaries retire. This results in a massive crash in circulating estradiol. I mean, we are talking a decrease of greater than 90%.
90%. That is not a gentle decline. That is a system crash.
It is drastic. And because there is almost no estradiol to send that quiet down signal back to the brain, the pituitary panics.
It doesn't get the feedback.
No feedback. So it goes into overdrive. It starts shouting louder and louder, trying to get a response that just isn't coming.
And we can actually measure that shouting in a lab test, right? That's how you know.
We can. That's the diagnostic marker. In a menopausal state, circulating FSH increases 10 to 15-fold. LH increases 4 to 5-fold. It's a huge jump.
Right.
So if we draw blood and the serum FSH is exceeding 40 international units per liter, that is the biochemical confirmation that ovarian function has ceased. The brain is screaming and the ovaries aren't listening.
It's so interesting because we usually think of menopause just as no more babies.
Yeah.
But the source material really highlights that the ovaries do a lot more than just manage reproduction. Losing that estrogen isn't just about fertility.
That's such a critical point. The ovaries are metabolic engines. They secrete androgens like testosterone and androstenedione, which we'll definitely discuss later. But more importantly, estrogen receptors are ubiquitous.
They're everywhere.
They are everywhere. They're in your brain, your bones, your blood vessels, your skin, your heart, your gut, you name it.
So when you pull the plug on estrogen, the fallout is completely systemic. It's not localized.
Completely. We see these profound metabolic shifts. There is an increase in central abdominal fat, that's visceral fat, which changes the body shape. That middle-age spread isn't just about diet, it's a hormonal redistribution of fat.
Okay.
We see changes in lipid profiles, which affects cholesterol. We see changes in vascular function, how your blood vessels react, and of course, bone metabolism. The body is fundamentally operating with a different chemical baseline.
Which leads us directly into the symptom landscape. Because that chemical shift, it manifests in ways that can really derail a person's quality of life. The source breaks this down into, what, 4 clinical presentations?
Yep.
We have the classic ones, obviously.
Yeah.
The ones everyone knows.
Vasomotor symptoms. That's the medical term for hot flushes and night sweats.
Which sounds so clinical and sterile for something that feels like you're standing on the surface of the sun.
It does. And physiologically, what's happening is a narrowing of the thermoneutral zone.
But what?
Your thermoneutral zone, it's the temperature range where your body doesn't have to do anything to warm up or cool down. It's comfortable. In menopause, that range gets incredibly narrow. So tiny changes in temperature trigger a massive cooling response, drenching sweat.
So your body's thermostat is just broken.
It's extremely sensitive. Broken, yes. Then there is the urogenital bucket. This is the one people are often hesitant to discuss, but it's so critical. Vaginal dryness, dyspareunia, which is the medical term for painful intercourse, and urogenital atrophy. The tissues literally thin and lose elasticity because they are starved of estrogen.
And that's not just a comfort issue, right? It can lead to other problems.
Oh, absolutely. It can lead to urinary issues as well, recurrent UTIs, urgency, incontinence. It all ties together.
And then there's the neurological and psychological bucket. This one's huge.
Yes. Sleep disturbances are huge, often driven by the night sweats, but also independent of them. Estrogen plays a role in sleep architecture itself. Then you have depression, anxiety, poor concentration, memory issues.
Brain fog.
The brain fog. So many women describe it as a fog that just will not lift. It's terrifying when you feel like you're losing your mind.
And there's physical stuff, too. It's not just in your head. Joint pain or arthralgia.
Yes, and sexual dysfunction that goes beyond just the physical dryness.
It's a full-body experience.
Yeah.
A hostile takeover.
It really is. And that's why the treatment hierarchy, the ladder of treatment, is so important. We don't just, throw the strongest drugs at everyone immediately.
Right. The source outlines a stepwise approach.
Yeah.
And step 1 is lifestyle changes.
For mild symptoms, yes. This is the first line. This means lowering the room temperature, dressing in layers, cutting back on caffeine and spicy foods, which are known triggers for hot flashes.
Like the classic triggers.
And, of course, quitting smoking and exercising.
Smoking cessation seems to be the first step in almost every medical protocol we review. It's incredible.
It really is. I mean, in this case, smoking affects how the liver metabolizes estrogen, and it also impacts vascular health, so it's a real double whammy for menopausal symptoms.
Okay, so that's step 1. What's step 2?
Non-hormonal topicals. If the main issue is just, say, mild vaginal dryness, you start with moisturizers or non-estrogenic creams. You treat the local issue locally.
That makes sense. You don't need a systemic pill for a local dryness problem.
You really don't.
But then we get to step 3, pharmacologic intervention. This is where we cross into hormone therapy, the big guns.
And this is reserved for moderate to severe symptoms or when the quality of life is significantly impacted. But there is a golden rule of prescribing here that is just hammered home in the guidelines. It's a mantra.
And what is that mantra?
Use hormone therapy at the lowest effective dose and for the shortest duration needed for symptom control.
Lowest dose, shortest time.
Exactly. The goal is to relieve symptoms and improve quality of life while minimizing adverse effects. It is not about restoring premenopausal levels just for the sake of the numbers.
So we aren't trying to make a 55-year-old body think it's 25 again.
No, we are trying to make the 55-year-old body comfortable and functional.
Okay, so we are at the point where a patient needs therapy. But we can't talk about hormone therapy without addressing the elephant in the room, the big SETI,
The WHI.
the Women's Health Initiative.
The WHI. It is the benchmark for safety data, but it's also the source of almost all the fear surrounding these medications. It changed the landscape of women's health overnight in 2002.
Because it was stopped early. Right. That's what made the headlines. Study halted due to cancer risk.
Yeah.
It was everywhere.
Yes, but we have to look at the nuance because the headlines missed a lot of it. A lot. There were two arms to this study, and mixing them up is where all the confusion lies.
Okay, well, let's break that down carefully. What was the first arm?
The first arm was the combined arm. These were women taking estrogen plus a progestogen.
And this arm was terminated after about, what, 5.2 years? Why?
Because of the occurrence of a pre-specified level of invasive breast cancer, they had safety monitors and they hit the safety limit.
So they saw more breast cancer than they expected.
Yes. They also found increased risk of coronary disease events, stroke, and pulmonary embolism in this group.
Okay, that sounds terrifying. I mean, that confirms the fear right there.
It does if you take it in isolation. But they also found benefits in that same group, significant decreases in hip, spine, and wrist fractures, and a decrease in colorectal cancer.
So it wasn't all bad news.
Not at all. But obviously, the breast cancer risk outweighed those benefits for that specific population in the study context.
Okay, but here is where it gets really, really interesting and where I think a lot of people get confused. There was a second arm of the study,
The second arm.
the estrogen-only arm.
Exactly. This arm consisted of women who had had a hysterectomy.
So they didn't have a uterus.
No uterus, and because they didn't have a uterus, they didn't need the progestogen. We'll explain why that is a rule in a minute. This arm was allowed to continue, but was stopped later, after about 7 years. And the reason for stopping was different.
So what did they find regarding breast cancer in the estrogen-only group? This is the key question.
This is the absolute key distinction. In the estrogen-only arm, no increase in breast cancer risk was observed during the study.
Wait, let me repeat that. The group taking just estrogen did not see an increase in breast cancer.
That is correct. 0 increased risk. In fact, some follow-up data years later actually suggested a slight reduction in breast cancer in that group. They also didn't see an increase in coronary heart disease risk.
That is a massive difference. One group, the combined group, had increased breast cancer and heart risks. The other did not.
A night and day difference. The estrogen-only group did show an increased risk of stroke, which is a known risk, and oddly, hip fracture. But the cancer and heart disease profile was completely different.
So what does that tell us?
It tells us that the risk profile is not just about hormones as a blanket term. It's specifically about which hormones and in what combination. It strongly suggests the progestogen component might be the driver of that increased breast cancer risk seen in the first arm.
And we also have to mention the dementia findings, because that's another scary headline that came out of the WHI.
Yes. In women who started the therapy age 65 and older, the estrogen plus progestogen therapy doubled the rate of dementia, including Alzheimer's.
Doubled it.
And it did not prevent mild cognitive impairment. This is why the guidelines today are very, very clear. Hormone therapy should not be used for the primary or secondary prevention of coronary heart disease or dementia.
Not a preventative.
It is not a fountain of youth for the brain or heart. It is for symptom management in recently menopausal women. The timing and the age you start really matter.
So if we are using it for symptom management, we have to talk about the rule of the uterus. This seems to be the very first decision point in prescribing.
It is the absolute fork in the road. If a woman has an intact uterus, she must take estrogen plus a progestogen, no exceptions.
Why? If the progestogen adds that risk we just talked about, why can't she just take the estrogen, especially if the estrogen-only arm had safer cancer results?
Because of the endometrium, the lining of the uterus. Estrogen is a growth hormone in this context. It tells that lining to grow and thicken every month.
To prepare for a potential pregnancy.
Exactly. But if you give unopposed estrogen without its partner, progestogen, that lining just keeps growing and growing unchecked. This leads to a condition called endometrial hyperplasia, and that significantly increases the risk of endometrial cancer.
So the progestogen is there to, what, put the brakes on, to clean things out?
Exactly. It stabilizes the lining and prevents that overgrowth. In a cyclic regimen, it triggers the lining to shed, like a period. In a continuous regimen, it keeps it thin. It protects the uterus from the estrogen.
Got it.
However, if a woman has had a hysterectomy, meaning the uterus is gone, she doesn't have an endometrium. She doesn't have that risk. Therefore, she can and should take estrogen alone, which, as we just noted, has a different and somewhat safer profile regarding breast cancer.
It's just a completely different risk calculation.
Totally different.
Okay, so let's talk about the estrogen itself. It comes in a million forms. Pills, patches, gels, sprays, creams. Is it just a matter of preference? Do you just pick what's convenient?
Not entirely. I mean, convenience plays a role, but there is a major physiological difference between taking a pill and using a patch or a gel. It's called the first pass effect.
The first pass effect. Unpack that for us.
When you swallow a pill oral estrogens like Premarin or Estrache, it goes into your stomach, is absorbed by the gut, and goes straight to the liver through what's called the portal vein before it ever enters your general circulation.
So the liver gets the first crack at it. It's like a bouncer at a club.
Exactly. The liver metabolizes a significant portion of it right away. This results in estrogen concentrations that are 3 to 6 times higher than estradiol, which isn't very physiologic. But more importantly, this big flood of estrogen hitting the liver stimulates the liver to produce certain proteins.
What kind of proteins?
It increases sex hormone-binding globulin, and crucially, it increases clotting parameters.
So the liver's reaction to the pill makes the blood slightly more prone to clotting.
Yes. It creates what we call a prothrombotic state. It also raises triglycerides.
Okay, I see the risk there.
Yeah.
And the patch. How does that change things?
Transdermal application, so patches, gels, sprays, they completely bypass the liver. The hormone goes right through the skin, into the tiny capillaries, and into the bloodstream.
So no bouncer. It sneaks in the back door.
It sneaks in the back door. This means you avoid that first pass metabolism. You get a much more physiologic ratio of estradiol to estrone. And most importantly, transdermal estrogen is much less likely to affect clotting factors or lipids.
So for someone with risk factors, say a history of migraines, liver disease, gallbladder disease, or high triglycerides, the patch is the safer route.
Absolutely. The guidelines explicitly recommend avoiding oral estrogen and using transdermal for women with hypertriglyceridemia or liver issues. For many, it's considered the safer default option now because of that lower clot risk.
Now, what about vaginal preparations? Creams, rings, tablets?
Those are primarily for local symptoms. If your only complaint is vaginal dryness or urogenital atrophy and you don't have systemic issues like hot flashes, you don't need to flood your whole body with hormones.
Right. Treat the problem where it lives.
Exactly. Vaginal creams, tablets, or rings like Estring have very low systemic absorption. They fix the tissue right where the problem is.
So you get the benefit without the systemic risk.
Generally, yes. The systemic absorption is minimal. And the local benefits are great. It reduces recurrent UTIs, can improve urge incontinence. It really restores the integrity of the tissue down there.
That sounds like a win-win for targeted treatment.
Yeah.
Now, the source also mentions dosage trends. Are we using less than we used to?
Oh, much less. The WHI used what we now consider very high doses. The evidence today shows that much lower doses, say 0.4 milligrams of conjugated equine estrogen instead of the old 0.625, are still effective for symptoms and protecting bone density, but without increasing things like endometrial hyperplasia as much.
The lowest effective dose.
Back to the mantra.
So let's look at the partner hormone. Progestogens. If you have a uterus, you need them. But there are different types and confusingly different schedules.
Yes, and this is where patient preference on bleeding comes in. This is a big conversation to have.
Bleeding? I thought the whole point of menopause was no more periods.
You would think. And for many women, that's the goal. But depending on how you take the progestogen, you might bring them back, at least for a while.
Okay, so what's the first option?
There is the continuous cyclic schedule. You take estrogen every single day, but you only add the progestogen for 12 to 14 days a month. This mimics a natural cycle.
So what happens when you stop the progestogen?
When you stop the progestogen for the month, the lining sheds. So about 90% of women on this regimen will have a scheduled, predictable withdrawal bleed, a period every month.
That seems unappealing for someone who is just celebrating being done with menstruation.
For many, it is. They do not want to see a period again. That's why there is the continuous combined method.
And how is that different?
With this, you take both estrogen and progestogen every single day. No breaks. This is designed to keep the lining thin and stable to prevent any monthly bleeding.
And does it work?
Eventually, yes. But, and this is a big but, initially you often get unpredictable spotting or bleeding while the lining thins out and adjusts. It can be annoying for the first 6 months or so. You have to counsel patients to be patient with it.
And what about side effects? Because progestogens are often the culprit for the things women complain about with HRT, right?
Yeah.
The PMS-like symptoms.
They can be difficult, yes. They are associated with irritability, headaches, mood swings, bloating, fluid retention. It's often a balancing act, finding the right type.
There are different types.
Oh, yeah. There's medroxyprogesterone acetate, or MPA, which was used in the WHI. It's synthetic. Then there's micronized progesterone, which is bioidentical to what the body makes. Some women tolerate one much better than the other. It can take some trial and error.
Now, what about the listener who is thinking, okay, this is all interesting, but I cannot take hormones? Maybe they have a personal history of breast cancer or a strong family history, or they are just not comfortable with the risk. Are they just out of luck?
No, not at all. There are actually quite a few decent options in the non-hormonal toolkit now. We often look first at SSRIs or SNRIs, certain antidepressants.
So drugs like venlafaxine and paroxetine,
Exactly.
are they used because menopause causes depression, or is it a different mechanism?
It's a different mechanism. This is distinct from treating depression, though it can help if that's also present. At lower doses, these drugs actually help regulate that faulty temperature control center in the brain. They widen that thermoneutral zone we talked about.
So they make the thermostat less sensitive.
Precisely. And there is a specific formulation of paroxetine called Brisdel. It's a very low dose, just 7.5 milligram, and it is FDA approved specifically for treating vasomotor symptoms. For hot flashes.
That's really good to know. Okay, what about gabapentin? Isn't that a nerve pain drug?
It is, but it's used off-label for hot flashes, and it can be quite effective, especially for night sweats. It seems to dampen the nerve firing that triggers the flash, but it comes with side effects like drowsiness and dizziness, so you often take it at night.
And then there's this really interesting category called SERMs, selective estrogen receptor modulators. This sounds like sci-fi tech.
It's actually brilliant pharmacology. Think of your estrogen receptors like locks on a door, and the drug is the key.
Okay.
A normal estrogen key opens every single lock in the house. A SERM is a special custom-cut key. It's designed to open some locks but jam others.
So it's selective.
It's selective. It acts as an agonist, turning things on in some tissues, and an antagonist, blocking things in others.
Can you give us a concrete example of how that helps?
Raloxifene is the classic one. It acts like estrogen in the bone, so it turns on the bone-building process and helps prevent osteoporosis. That's the agonist effect.
Get your bones.
Very good for bones. But it acts as an anti-estrogen in the breast, so it blocks the receptor there and can reduce breast cancer risk. That's the antagonist effect.
That sounds perfect. The holy grail. Bones protected, breast protected. What's the catch?
The catch is the brain. It can act as an anti-estrogen in the brain's temperature center, so raloxifene can actually worsen vasomotor symptoms. Oh, no.
Yeah, it can make hot flashes worse.
Cool. Great for bones, bad for sweats. You can't win.
Exactly. There is another one called ospemifene. It's approved for dyspareunia, painful sex. It acts like an estrogen agonist in the vaginal tissue to restore it, but, and there's always a but, it comes with a warning that it can increase the risk of stroke and DVT, similar to estrogen, and if you have a uterus, you still have to be careful about the endometrial lining.
So you mentioned androgenic activity earlier. That brings us to section 7, testosterone. We usually think of this as the male hormone, but women produce it too. Why would a postmenopausal woman take testosterone?
The primary indication is for hypoactive sexual desire disorder, a persistent lack of libido that causes distress. The source notes that while it's still somewhat controversial, its use is becoming much more widespread.
Why?
Postmenopausal women can experience a significant drop not just in estrogen, but also in their natural testosterone production from the ovaries and adrenal glands, and that can really impact sexual desire and responsiveness.
And does adding it back actually work? The evidence suggests it can, yes. Testosterone, sometimes combined with estrogen, can improve the quality of the sexual experience, desire, and arousal. But safety is a real concern here.
What are the specific risks?
Well, the long-term safety is still undetermined regarding breast and heart health. The data just isn't there yet. And the short-term side effects can be distressing. Virilization.
Virilization, meaning?
Meaning developing male pattern characteristics, unwanted hair growth on the face or chest, a deepening of the voice, acne, even clitoral enlargement, plus adverse effects on lipids and fluid retention.
So it requires very careful dosing and monitoring.
Extremely careful. You do not want to overshoot the normal physiological range for women. This is not something to play around with.
Okay, so if a listener decides to go down the hormone therapy route with any of these options, it's not a set it and forget it situation. Monitoring is crucial. What does that look like?
Absolutely. You need a follow-up about 6 weeks after starting. That's the first check-in.
What are you looking for?
2 main things. Is the dose effectively treating the symptoms? Are your hot flashes better? Are you sleeping? And second, what is the bleeding pattern like? Is it what we expected?
And after that initial check-in, what about annually?
The full workup. Breast exams and mammograms are non-negotiable. Pelvic exams, blood pressure checks, because oral estrogen can raise blood pressure in some women.
And what about bone density?
Good question. A baseline bone mineral density test is recommended for women over 65 or for younger women who have other risk factors for osteoporosis. We need to keep an eye on the skeleton because menopause accelerates bone loss significantly.
And there's a specific warning in the source about endometrial surveillance.
Yeah.
You have to watch the bleeding. When should a woman be worried?
This is so important. If you are on a sequential therapy where you expect a monthly bleed, you need a biopsy if that bleeding happens at an unexpected time or if it's suddenly unusually heavy.
And if you're on the continuous combined, the no-bleed kind.
If you are on the continuous combined therapy, where you shouldn't be bleeding after the initial adjustment period, and you have irregular bleeding that persists for more than 6 months, you need to get it checked.
You need a biopsy of the lining.
You need to check the lining to rule out hyperplasia or cancer. Never, ever ignore unexpected postmenopausal bleeding. It's a red flag.
So let's bring this all together. We've covered the biology, the drugs, the scary studies, and the alternatives. What does this all mean for the person listening, trying to make a decision?
It means that menopause management is not one size fits all. It is a highly individual calculation, a conversation. You have to balance the severity of your symptoms. Are the hot flashes ruining your career? Is the lack of sleep destroying your mental health against your specific personal risks?
So you have to know your own health profile.
Do you have a uterus? Do you have a personal or family history of clots? Do you have a strong family history of breast cancer? What's your bone density? It's all part of the equation.
And I think the biggest takeaway for me from all of this is that distinction regarding the WHI study. It bears repeating. The risk of estrogen-only therapy is not the same as combined therapy. That nuance gets lost so often in the public conversation.
It really does. It's the single most important detail that got lost. And also realizing that transdermal options, the patches and gels, can mitigate some of the clotting risks adds another layer of options for women who might have been told no in the past. It turns a binary yes-no decision into a whole spectrum of choices.
Before we sign off, there was one thought in the source material that really stuck with me. A kind of paradox. It mentioned that women with vasomotor symptoms, the hot flashes, usually see mental health benefits from therapy. Their mood improves, the fog lifts.
Right.
But women without those symptoms, who maybe take it for another reason, might actually see a worsened quality of life on hormones. Their mood might get worse.
It's a fascinating observation. It suggests the mood benefit might not be a direct chemical effect of estrogen on the mood centers of the brain.
Exactly. It raises a provocative question. Is the hormone itself the healer that fixes the mood? Or is the healing simply the result of, finally, after months or years of night sweats, getting a solid, uninterrupted, good night's sleep?
That is the million-dollar question, isn't it? Sleep is powerful medicine. If you treat the sleep disruption, you often treat the irritability and the fog that comes with it. Is it the hormone, or is it the sleep the hormone provides?
Something to think about. That's it for this deep dive into hormone therapy. We hope you feel a little more equipped to navigate this puzzle.
Stay curious and stay healthy.
See you next time.